Hello.
Hello. Dr. Adina, Facebook Live is going on now. YouTube also.
YouTube Live is good.
YouTube Live is going on. Okay, fine.
Yeah.
Facebook, FB?
No, only YouTube right now.
FB we will upload later, right?
Yeah, yes, later.
Okay, fine. Yeah. Hi, I can see Dr. Kevin. Hi, Kevin. How are you? Kevin, just unmute your speaker.
I am fine, sir. I am fine, sir.
Okay, nice to meet you. After
Thank
a
you,
long
sir.
time,
Thank
I'm
you.
seeing you.
Yes, sir. Yes, sir.
So welcome all participants joining.
Yeah, I think we can start now, Dr. Vijay.
Yeah, we can start. We can start. It's already at 10:35, right? Yeah. Dr. Adina.
Yes, sir, we can start.
Okay. So very good morning, my dear friends and colleagues. So welcome to another master show from a senior academician and a senior clinician. And we are proud to say he is one of our member also, Dr. Ganesh, Professor Dr. Ganesh. He's a professor and former HOD of Sri Shankara Dental College, and he is the editor general of Kerala Conservative Association Journal. And today he is going to talk about managing the root apexes. Even the clinicians, even the other specialty doctors also, they will be also benefited from his talk. And today I'm really happy. It's the 13th CDA program from Article IDA. In this COVID time, it's not a small thing. When I took charge of the Article IDA, I just, in my introduction speech itself, I told, my young turkeys will rock the show. All the conveners, they're just going with their promises, and we are having a very good idea here this time. And it's the 13th program. And I really congratulate our CDE convener, Dr. Adina, for doing this super duper things for our branch. And I am very much thankful to Professor Ganesh also. He is our member. And being a senior faculty, it's our privilege to have a CDE program from Dr. Ganesh. And I am very sure our participants will be delighted. And it's over to you, Dr. Ganesh. Thank you all the members, and we will start the program now. Thank you. Dr. Ganesh, please start.
Thank you, Dr. Sharon, President IDA Athingal, for the warm introduction. Thank you, Dr. Deepak, Secretary, and Dr. Adina, who is the CD convener of IDA Athingal. And a special thanks to Dr. Biju for making all this happen, and all the IDA members and the executive committee especially for being here and attending the talk. So my topic for the day will be managing the apex, which is really the Achilles heel, or the what we call the weak point in dealing with endodontic treatment. We have a lot of advances in endodontic treatment, including access cavity preparation, the cleaning and shaping, the obturation. But can we really have a 100% mastery over the endodontic treatment unless we learn to master the anatomy and the morphology of the apex? So this is what I'll be trying to address to you in this lecture. Now, before we go into the coronal apical third, there's always a discussion in endodontic forums about the importance between coronal seal and apical seal. Before I start off, I would like to first of all emphasize that both are of equal importance. I'm not trying to say that apical seal is more important than the coronal seal or vice versa, but both are of apical, both are of utmost importance in endodontic treatment, because both, as Cohen in his textbook always tells, act as a pathway to the pulp. And pathway to the pulp always brings microorganisms and fluids which can infect the pulp space, which can lead to a periapical or a granuloma or abscess or whatever. So this is what normal, not normal, apical third of the tooth can look like. And what we're trying to do in a root canal treatment is try to get a hermetic seal. Hermetic seal, as you all know, basically means sealed against the escape or incoming of air or fluid. So that is, as you all know, is impossible in doing in a root canal treatment because of the glorious uncertainties of the root apex and the root canal system. So what we are trying to do basically is to clean as much as possible the root canal space and seal it so that none of the microorganisms enter or whatever is entrapped inside doesn't leave. So you're trying to entomb the whatever the microorganisms are present inside the microorganisms inside the pulp space and prevent further ingress of microorganisms. The ingress of microorganisms is basically done with the help of coronal seal, and whatever is and apical seal, and whatever you don't want to go outside is also done with the help of a apical seal. So that is the importance of coronal seal and the apical seal. Now, what is the importance of the apical third? Morphologically, it's the most complex region of the tooth. Therapeutically, in the treatment aspect, it's the most challenging part, but prognosis-wise, it is the most important area because cleaning and shaping of that area is most critical to the outcome of endodontic treatment. If you remember your rationale of endodontics, which you have studied in your BDS or during a postgraduate, the primary focus of infection in the is the tooth pulp space. The pulp chamber gets infected, the microorganisms divide and go to the pulp apical third, which causes the periapical damage or the granuloma or the periapical periodontitis. So the actual microorganisms are in the pulp space or the apical third. So prognosis wise, cleaning and shaping of that area is going to be the most critical in your endodontic outcome. And radiographically, as you know, it's the most obscure and most unclear area of the root apex because we're trying to clean the three-dimensional area. You don't get the three-dimensional area in the radiograph. You have to go in for newer diagnostic measures. So that is why it is important. And the brief knowledge of the small zone apical third, the basic problem with the apical third is again that it forms after the crown erupts and becomes functional. So it is always changing. 7-year-olds, erupted tooths, unformed tooth is not the same as a 10-year-olds. It's not the same as a 12-year-old, 15, 20, even 30, 40. It adjusts to the physiological and functional movement of the tooth. And unfortunately, with the age and time, the apical foramen and the root changes, location, size, and the morphology. Now, what happens in a apical or accessory? We all know accessory canals or lateral canals. All lateral canals are accessory canals because accessory canals are canals which divide from the pulp space into the open space, of periodontal space. But lateral canals are seen mainly in the coronal third, that is this portion, or the middle root of the tooth. That is where lateral canals. And the most problem which happens is with the apical delta, which is formed mainly due to the breakage of the HERS or the Hertwig's epithelial root sheath. So this is a cross section of what we are dealing with. This looks like a premolar, a lower mandibular premolar. This is what we are trying to do root canal and clean and shape with. In effective aging, as I already just mentioned, the root length increases over age with the deposition of cementum, but the working length does not increase. It's almost the same or it decreases because it's a cementum which is getting deposited and the root length is not changing as much, but the tooth length or radiographic length is changing. So that probably explains a lot of more success in older individuals. 50, 60 years old, the success rate is much higher because we tend to under-obturate or obturate 2-3 millimeters short of the apex. Now, why is it more difficult? It is difficult because the internal anatomy of the apical part is often not discernible in an X-ray. X-ray, as you all know, is a two-dimensional image of a three-dimensional object. So the third dimension is not accessible in an X-ray. But the problem is that the treatment is always gauged by the way the filling appears in the apex. I always used to tell my friends and students, if you show a post-obturation X-ray to a endodontist or a general practitioner, you show 20 people, you will get not 20, you will get 40 opinions. They'll tell you it's short, they'll tell you it's the apical, the cleaning and shaping is less, they'll tell it's not condensed well. So that's the problem. Our treatment is always assessed by the X-ray view of the tooth. And unfortunately for us endodontists and all the general practitioners, this X-ray or this thing is going to remain in the patient's mouth till that tooth is extracted or the patient passes away. So that is always there for 10, 20, 30, 40 years. That tooth is there with your root canal filling for anybody to take an X-ray, OPG, whatever, and then give an opinion. Okay, that is a problem. So we better, it's not a problem, so we better give more importance to the apical third. So canals can be calcified. So pulp chamber calcification is really common with pulp stones. The orifice can be calcified, but rarely the apical third is calcified. Even though in the X-ray we very rarely, we can't see the apical third. The calcification of the apical third is pretty rare. Now, coming to what do you call the endodontic triad, that is the axis, the disinfection, which includes the cleaning and shaping. I've just changed the shaping and cleaning vice versa just for showing purpose, and the obturation. These three form the triad of endodontic treatment. You have to have a good axis to do a good cleaning and shaping, and you have to have a good cleaning and shaping to do a good obturation. But now in 2020, we have solved a lot of problems with endodontics. So what are the problems which we don't have? So one is skill, which is left to the operator, which you have to have, which I'm not talking about, which is taken for granted, I suppose. That skill is always required to do endodontic treatment. But when it comes to the actual procedure, we have, as I told you, three basic procedures, that is axis, disinfection, and obturation. Axis is almost ticked. If you have the skill, we have a lot of instruments, we have a lot of techniques to do a good axis. So that is not a problem nowadays. If you have a good technique and knowledge of the pulp face anatomy and a good armamentarium, axis should not be a problem. So what comes next in disinfection? It is the shaping. Shaping has undergone drastic change over the last 20 years with the advent of rotary endodontics. Now, if you can do axis cavity preparation and you can locate the canals, cleaning and shaping is left, shaping is left with your instruments. We all started with profile. It was introduced by Ben Johnson. It's come down to light speed by Senior, a lot of instruments. But with the advent of newer instruments, which is coating the instruments with special metallurgic alloys, the breakage of instruments have come down drastically. So shaping is no longer much of a problem. You can just select from an array of instruments which are available, starting from the axis cavity, orifice shapeness, to the middle third, to the apex. So shaping is not a problem. But shaping is just half the job done. You are just shaping nowadays. The now present concept is that you are just shaping it so that you can do a good cleaning and obturation. Shaping does not end all your troubles in endodontic treatment. The concept has changed. Now, a good obturation with a good 25 or 30 size apex with a greater taper, with a very good single cone obturation doesn't mean that your root canal is going to survive 10 years or 15 years. I'm telling 10 years, that's because that's the normal. 10 years is the time we give for a biological medical procedure to assess the success rate. So what is the problem? The problem is, are you cleaning the root canal space completely? You are shaping it. Nowadays, what happens is you just do the axis, you take the orifice shape now, you do the coronal widening, do 25, 6%, 4%, put in a GP, leave it. But is it clean? I showed you a photo of the earlier apex. How are you going to clean that? Naturally, you're not going to fill up three-dimensionally. It's very tough to three-dimensionally fill the whole root canal. But you can, of course, try and clean it. So that is where the problem comes. And the last is the obturation. Unless you do a good cleaning and shaping, you're not going to get a good obturation. What you show in your post-operative radiograph is actually what you have done during your cleaning and shaping. If you do a bad shaping and cleaning, you're going to have a bad obturation. If you do a good cleaning and shaping, you're going to have a better or a very good post-obturation X-ray and a very good prognosis for the tooth. So all this led to somebody, as you can see in the pictures I've said, these are all micro CT images of upper and lower mandibular molars. This is the upper and this is the lower mandibular molars taken by my one Mr. Stephen. And this is what we're trying to manage in our day-to-day affair. Now, are we 100% sure we're going to clean and shape all this? Obviously, no. Why? Because we're not seeing it. We cannot clean and shape something which you cannot see. It's ultimately a semi-blind procedure. You're not seeing beyond the coronal orifice, the coronal orifice. So this is what you are dealing, at least in the molar region, at least what you're dealing in a day-to-day practice. And it's very difficult. And this led to a famous scientific academician, Langland, as early as I think 20 years back, to pronounce that endodontics is an inaccurate art based on precise science. There's nothing more which conveys what endodontist does more than that. It's an inaccurate art because we are not 100% sure the apical third where we are going, but it's based on precise science. We know what to do. We know what needs to be done. But still, we have around 95% success rate. That means we are doing something right. Okay, 95% is I think the maximum success rate for any medical procedure we can get. We are still doing something right. We are getting there, and it is increasing, but it's still an inaccurate art because we cannot see where we are working and where we are going. Now, this is a famous Washington study on where to end the filling. This was again done, I think, 20, 25 years back. So it's changed. Most of it must have changed nowadays. The recent studies. What we're told that in 94% success rate is when you obturate or end the filling point 0 to 2 millimeters short of the apex. And if it's more than 2 millimeter, it's around 68%. And if it is beyond the apex, it is 76%. But this does not have clinical significance. So basically, if you want to have a good success rate of around 94%, you have to be between 0 to 2 millimeter of the apex. And this overfilling, I'll just mention later. We did a small study when I was the head of department around 3-4 years back among endodontists and general practitioners. We asked them where you want to end the root canal obturation. And 65% told 0.5, okay, 15%, 16% told at the apex, 1 millimeter told, 18.4% told 1 millimeter short. So this is the basic outcome of the survey. And according to experience, around 71%, okay, told it is 0.5 millimeter short of the apex. That is less than 10 years of experience. Now, what is the importance of the working length? Because working length, as you all know, is the distance from the coronal reference point to the place where you are going to end your root canal treatment. That definition itself means that it is the operator which decides the working length. There is no hard and fast rule that this tooth length, this average length of tooth, this has to be the working length. The operator, the clinician, the endodontist, you decide the working length. If you feel there's resorption, you are welcome to reduce it 2 millimeter, 3 millimeter. If you feel that this is a vital tooth, you need to go 0.5, you can go. So the working length definition itself gives you the prerogative to where to end the root canal. Basically, the importance lies in the fact that the pulp tissue, vital pulp tissue, the necrotic debris in non-vital, which contains a microorganism, all have to be cleaned as far as possible. For this, accuracy of the root canal length is critical. This was actually researched and found. It's not something new. 30 years back, it's been somebody, Wayne and Langland have decided, and Cutler, who gave the classic study on minor and major diameter, it's almost done almost 75 years back. So the actual concept is not new. Now coming to the difference between vital and non-vital teeth on where to end the root canal. A lot of people ask me, is it the same for a vital tooth and a non-vital tooth? The treatment options for a vital tooth and non-vital are not the same. Basically because, as you have learned in your UG and PG, a vital tooth, when it has irreversible pulpitis, it is basically inflammation of the pulp. You can see here, the pulp is inflamed with the ingress of toxins from the microorganisms. The majority of the pulp is intact. The pulp chamber, the pulp in the pulp chamber is inflamed, which causes the severe pain. That does not mean the root canal pulp is infected. The pain is basically due to the closed space and the lack of space for inflammation of the tissue. That's what gives it the severe pain. But when it is infected, the microorganisms and the toxins have traveled all the way to the apical third and caused a periapical reaction. It has reached the bone, it has reached the periapical region. It is no longer confined inside the root canal. This is the periapical. So your treatment options change. And naturally, in a retreatment, in a infected tooth, again, your root canal treatment has failed because there is something wrong with your root canal space. So you have to redo it. The basic treatment strategy changes in that you can do a single visit if you want for a vital tooth which has got irreversible pulpitis, but it is not often advocated in an infected tooth with a periapical. That is again left to your clinical judgment. If you feel you have done cleaning and shaping, the patient is asymptomatic, you can go ahead with single visit. But if you feel that the patient needs to have another visit, you need to place a intracanal medicament. It is dicey and it can go in for a flare-up. You need to give a multiple visit for the patient. And retreatment, of course, if you ask me, I will always do it in a multiple visit, 2-3 appointments. Please go ahead. Don't do it in a single. It's my opinion, and that's what's basically done. So the root canal length also differs for vital and non-vital. In a vital, most of the academicians recommend to stop at the apical construction. I'll come back I'll come to that later. But in a non-vital tooth, it is sometimes better to go beyond, especially when there's a large periapical lesion or when there is a granuloma or abscess, you want to drain it. You can just pass an instrument through the apex and try to drain it, or try and clean the apical foramen, or you can often inject the intracanal medicament into the periapex. Most of the intracanal medicaments which contain iodoform like Netapex have excellent bone healing properties and won't do any harm if you inject some into the periapical region. Apical patency, which was advocated by Buchanan, is caused a lot of controversy in the endodontic world. He advocated passing a low size file through the apex as a part of recapitulation to maintain the patency. It is still taught in some US schools. I think last I heard is around 40%, 50% of the schools in US still teach it. It's highly controversial in a vital tooth because they don't advocate altering the periapical tissue. What happens is, in an abscess case, you can, of course, you can just pass it to drain the abscess. And there is something known as a local adaptation syndrome, which is what is usually seen in a acute pulpitis case, which sort of settles down. If you have, during your UG classes, you have heard about the Cronfield's mountain pass theory. The microorganisms reach here, but the body's immune mechanism sort of seals it off, and there is a sort of local adaptation to the microorganisms and the body's immune system. That is the status quo. That is sealed off for the time being. The moment you enter with the instrument, you can provoke a flare-up. So that is why you have to be careful while dealing with non-vital cases. Now, what are the methods? A lot of methods these are some of the methods which have been advocated, which are tactile, pretty useful, but cannot be taken as the final. Paper point is also useful, especially when you have a perforation. You can just dry the canal, insert the paper point, and it can tell you which side the perforation is on, or it can tell you whether the canal is exiting to one side. It's very useful, but not used much, but I can tell you it's useful. Now, coming to the most two important things is the radiographs and the electronic apex locators. Now, what are the landmarks? We have, as you all know, something known as the radiographic apex, and we have something known as the apical constriction. The apical constriction mostly coincides with the minor diameter, and the radiographic apex most of the times coincides with the major diameter. So this photo shows you the difference between the canal length and the root length. If you take the X-ray, this will be your canal length, but the root is exiting towards the side. So if you don't have a proper X-ray or a proper apex locator, you're going to come here and then going to work your way all down here. You're going to perforate, create another axillary opening. This is what happens. The apical constriction is the most important area where you should concentrate when you're dealing with root canal treatment. The location and shape, you all know this is a major diameter. This is a very simple diagram which I'm showing you. I'll show you a diagram again. This is a major diameter. This is the minor diameter of the apical constriction, which coincides with the cemento-dentinal junction. That means there should be some amount of cementum formation there. Cementum formation takes place when there is, the logic behind that is when there is cementum formation, there is usually an absence of pulp, because the pulp is there, they will mostly deposit dentin. So that is the logic the Grove used in 1955 to emphasize that the cemento-enamel junction denotes the beginning of the periapical area. Another common problem we feel is that the wider apical diameter and the narrow internal diameter. This is I showed you, is a very simplified diagram. This is shows the narrowest portion here and the widest portion here. I'll show you a diagram again which shows the actual area. So this is what it can look like. Okay. So when you have a radiographic apex, this is what your radiographic apex is going to look. Because you're not going to have a clear picture of this root on the X-ray. So you're going to take your file up to the radiographic apex, reduce 0.5 millimeter is still going to be beyond the apex. And what do you do when you have an apical delta? You're going to push it all the way and destroy the apical delta and then fill the root canal space. Now, coming to apical constriction, where this is the minor diameter. The minor diameter is a histological and theoretical concept, and according to the latest glossary of endodontic terms in 2020, the apical constriction, a minor apical diameter of a minor diameter, is the apical portion of the root canal having the narrowest diameter. The position may vary, but it is usually 0.5 to 1 millimeter short of the apical foramen. So that is where the main apical constriction lies. Does the apical constriction coincide with the minor diameter? That is again a question which needs to be answered. So coming to apex locators. So apex locators, basically, most of them will tell you when you reach the periapical region. It does not show you, most of the apex locators do not show you whether you are 1 millimeter short, 2 millimeter short. They will have readings from the apex locator, but they do not show you the exact millimeter. They'll have 2 millimeter, 3, 4, 5 readings on the apex locator, but they do not show the exact millimeter from the apex. They'll just show you when you have reached the apex. So this is a diagram of the synodental junction. So this is where your apex locator usually will show you that you have reached the apex. So this is another diagram of the apical construction, which shows the different types. Traditional tapering can be partial constriction and the multicentric constriction. Again, a few studies which shows the unevenness of the apical constrictions. This is a maxillary central incisor. So apex locator is basically show you the apex here. But radiographically, what you're going to do is you're going to go here. That is where you have to make a difference. So maxillary molars, they found in palatal roots especially, they found that the apical constriction is not very reliable mark because the palatal root is very large root and the apex is often towards the buccal or the palatal or the buccal side, and so it's not a often reliable constriction. But in mandibular molars, they showed that the cross section was evaluated into supposed to be 0.2 millimeters and it was in close proximity to the foramen. So it differs in upper and lower also. So does it mean the apical constriction is located? As I told you, this is the radiographic apex, this is the periapical tissue, and this is where your electronic apex locators will show you the reading of apex or where you have reached the periapical tissue. So if you're using root SEDEX, which I use, if you get to reach the apex, the 0 point, and then reduce 0.5 or 0.5 or 1 millimeter according to your clinical judgment. Now again, the survey which was done on endodontists and general practitioners, which asked which histological landmark do you consider as ideal to determine the working length. 61% told apical constriction and 33% told minor foramen. So that's all. Most of the people have a good idea of where to. And you take a preoperative radiograph, always said 61%, mostly so around 91% take preoperative radiograph. Do not go in for endodontic treatment without operative radiograph. I think most of you will know it, so I'm not trying to emphasize on it more. Do you use an apex locator? Again, 90% use. I think it's a very good thing. And the reason for not using apex locator, this was done around 4 years back. The cost and time was one of the most common reason. Cost, I can agree, it was costly, around 60,000 rupees for a good apex locators, but not so nowadays. You get a good apex locator for 10, 15, 20. Earlier, they were not very efficient, but nowadays most of the people are using it. My friends tell me they're pretty good. So cost should not be a reason for not using an apex locator. Time is absolutely not a reason for not using. If you're not using an apex locator, you're saving on time, but you're playing with fire. You are not going to do a good endodontic treatment. And not reliable and not needed, almost 48%. So I think we should go back and think about it, because reliability is much, much better in recent apex locators. Type of apex locators, root SEDEX, as I told you, is a gold standard. I used to recommend it to all my students. It's costly, but it works for a long period. It's worth the investment. But nowadays you have good economical, I won't call it cheaper, economical root canal apex locators. Woodpecker has got it. I think Meta Dent has got it. A lot of companies ask around for people who have used it, get opinions from endodontists and general practitioners, and and buy a good apex locator if you can't afford a root ZX. But if you can, try and get a root ZX. Mini is around 50 to 55 nowadays. So how many times do you have to use it? Most people use it twice, before and after, or if it's widening, that should be the normal method, because after cleaning and shaping, the root canal length tends to differ because of something known as zipping or transportation of the apical portion. In a curved root, once you've done the root canal, especially with stiff instruments and 6% taper instruments, you tend to straighten the canal. So your apex changes slightly, the working length can change. So it's always advisable to use it before and after cleaning and shaping. Which method do you use? 64% told both X-rays and apex locators, well and good. So what is the sequence? Again, most told preoperative radiographs and then working length X-ray and then apex locators. I'll come to one of my experience what is best. Do you take post-obturation radiograph? Mostly again, most of them take post-obturation radiographs, which is again good. One of the reasons you need to take post-obturation radiographs is one reason my friend and professor used to tell me, because the best time to do a retreatment is post-obturation. You don't take a post-obturation radiograph, you wait for 6 months or 6 days, you take a radiograph, find it short, over, and then the sealer is set, you try and do a retreatment, it's going to be very difficult. If you want to do a retreatment, if you feel it has gone beyond or short, take a post-obturation radiograph and do it then and there. So the best time to do a retreatment of your own case is then and then. Take a post-obturation radiograph and correct it before the sealer sets, and you can, before the sealer sets and you have a tough time removing it. So which working length determination technique do you think is more reliable? Both. I think the people who are playing it safe, they don't want to get into commit themselves. We all do that in surveys, even though it's an anonymous survey, we'll just be safe and give a safe answer. So here is something which is very interesting. In case of a discrepancy between radiographic length and apex locator, which length will you prefer? Half of them told radiographs, half of them told EALs or apex locators. And 13%, the fence sitters, as I call them, take an average. That's the safest one, take an average. So that's very easy. But what the problem here is radiograph. This is a very tricky question. Even I never had an answer. I still don't have a 100% answer. But whom do you trust? What you see with your eyes or something which your machine tells you? That is something which I will try to explain with some of my clinical cases. Okay. Now, what is the clinical relevance of what I just asked now? Which will you trust, the radiograph or the apex locator? I will come to this case first. Sorry for the poor quality of the radiograph and the absence of a rubber dam. So this case was come for second opinion. They have started a root canal treatment for periodontal reasons. They have taken a master cone X-ray. They have found something fishy on the 7. So they sent it to one of the clinics I go for consultation. I took multiple X-rays to check, and nothing could be seen on the radiograph. We couldn't find anything on the radiograph, but on the usage of an apex locator on the parietal root of the 7, it was giving an abnormal reading. Around 10 millimeter, it was showing apex. It was showing beyond the apex. It was beeping all over the place. So I took a master cone, which I haven't included here. I think this is a master cone. Again, the radiograph is pretty bad. I took a master cone and it showed perfect working length. It's going all the way to the apex. There's nothing wrong. So my instinct told me there's something wrong. Okay, the apex locator, when it shows you there's something wrong, usually there is something wrong. You have to go with the apex locator. So luckily for this case, I was able to convince the practitioner in that clinic and the patient to go for a CBCT. Okay, CBCT showed a horizontal fracture in the palatal root. These are different views. Showed a horizontal fracture, which was not visible in the radiograph. And believe me, I have done cleaning and shaping also on that root. I have done a cleaning, I have done irrigation, I have done shaping, 6%, 25. I didn't use 30 because once I just did the coronal orifice widening, I put the apex locator. The biggest lesson you should take out of this case is that not that you should use an apex locator. You should, that is not an option nowadays. It is to be used if you're doing root canal treatment. The biggest lesson I got personally from this case is that you have to use the apex locator in all the canals of the tooth. Most often, when I've done it, you just take palatal and one mesiobuccal, the next patient is waiting. You just take it won't differ much, we'll correct it in the master cone. The master cone X-ray is not going to show you the real truth which lies in the tooth. So the biggest point I got, this is I think I did it 2-3 years back, is you have to use your apex locator in all the canals. Even if you know the root length, even if you are sure there's no problem with the root length, you have to use it in all the canals, because the apex locator not only shows you the length, but it also shows you whether there is any discrepancy. There is a perforation, there is a strip perforation, there is a resorption, there is a fracture. Okay, so you have to use an apex locator and you have to use it in all the canals. And this is another case which was referred to me by a surgeon. Patient had undergone multiple surgeries in pedo department, lot of at least 3 surgeries, and the person had an abscess with a sinus, had come to me for re-RCT and surgery. Was very young patient, was around 20, 21 at that time. I absolutely ruled out surgery because the crown root ratio was already very bad. The patient was young, didn't want to go for extraction. So I gave him the option of just doing a retreatment and waiting. So the patient agreed. So this was in 2019 January. I reopened it, removed as much as GP and sealer as possible, placed Metapex, and followed it up for 6 months. When you have such a lesion and you don't want to do surgery, you have to try and do a treatment. You have to have patience. I did every appointment every month for 6 months, changed Metapex for 3 months. Antibiotic paste for another 3 months. The lesion had come down to this amount. I did the obturation, but even then, the lesion was not closing down completely, and I had some problem. So one of the X-rays which I took in an angulation showed a lateral canal here. Can you see? There was a lateral canal. So again, I was very scared that was it a perforation done earlier? Was it done by me? Because so very large apical preparation, canal preparation done, chances of perforation are more. But did I do a perforation? I was scared to obturate. Patient didn't want to go for a CBCT. So what came to my rescue is an apex locator again. I inserted the file inserted the file into this, and it showed that it is still inside the canal. Showed a working length of around 16 millimeter, which gave me the confidence to go ahead and obturate both the canals. You can see the obturated canal here. If it was a perforation, the sealer would have gone all over the place, but it is a GP there. And this is an X-ray I took 2 months back. It's almost 1.5 years since the patient came to me, 6 months post-operative X-ray, and gave a wonderful Remax crown. And touch wood, the patient is very happy. Hope it stays. And this, as I told you, is a apex locator, is a lifesaver. This is a case I did yesterday. actually in Dr. Rudy's clinic. Rudy is here, I presume. Again, a patient came, referred. This was done pre-corona. Patient reported to Dr. Rudy. He did a pulpotomy. The root was still forming. So after 6 months, the patient had some sort of issue. Went to a local dentist. He was not from Trivandrum. They did an axis opening. This is not done by me, so don't look at me. So this was done by somebody else. So the apex had formed to an extent, but he was having trouble because the working length he took showed around 23 millimeters, but the patient was having pain at around 20-21 millimeters. So I had gone there yesterday, tried with my apex locator. It's a wide open apex, so you can't trust an apex locator very much in this. But even then, it showed around 20 millimeters, which is showing some sort of apex reached. So I tested a 21-meter gauge needle and gave a metapex dressing. This again, you have to get the patient into, tell the patient what's going to happen. I told them you have to wait for 3-4 months. If you want a immediate treatment, you have to go for a MTA placement or a surgery. Surgery is not advocated in this MTA placement. So what happened in this is probably that if you look at this, the tooth formation is something like this. This will be the buccal, or this will be the palatal, or vice versa. The tooth will be formed in an angulation. So when you look at the radiographic portion, this is where you will get 23 millimeters. But it is short probably. I have seen one or two cases in my clinic where you feel there is resorption. But when you remove the tooth, the entire labral portion is resorbed. The palatal portion is intact. You can see the GP. So if I had tried to do a root canal retreatment, the whole thing would have been exposed. On extraction, you can see the entire labral portion is exposed. But on X-ray, you see that it looks like this. You can't make out whether it's restored. That's again where your root canal treatment comes into a problem, and you have to use a apex locator or your diagnostic tools. This is another reason you have to use an apex locator. You can't make out the X-ray in apex in all cases, especially in anterior maxillary teeth where you have the shadow coming in of the zygoma, where you have an impacted tooth, and especially when you don't want to use the radiograph in a pregnant patient. So if you ask me, doing root canal treatment without radiograph is like driving in the rain without wiper. You can make out where you're going, you can make out what is happening, but you can never clearly tell what is in front of you. So if you're doing a root canal, if you're doing endo procedures, get a apex locator. It really saves you a lot of headache. So working length, again I told you, use radiographs to ascertain the initial working length. Okay, then use a apex locator. So take home, clinical point of termination is subjective. Cleaning should be done till the apical constriction. The judicious use of a radiograph and EAL. Use CBCTs when encountering complex anatomy. It's not very expensive. It's around, I think, 1,500. You will get a limited field of view, and that is nothing with the peace of mind you will get once you diagnose properly. So my protocol for using an apex locator is as follows. You can develop your own, but from my experience, for the those who are using, use the X-ray to have a basic idea of how much your root canal length will be. Okay, take a good radiograph, determine it's around 19 millimeter. Use orifice widening shapers using whatever instrument you're using. I used Hero Gold. Use orifice shapener. Widen the orifice, because if you don't widen the orifice, you are going to get a wrong reading. You won't get a reading. It won't show you because the file is going to get stuck in the coronal. Do a good coronal widening. Use your apex locator along with your predetermined working length to find out the apex. Do the cleaning and shaping and test with a master cone radiograph. This is the basic thing which should be followed. If there is a discrepancy between your apex locators and your radiograph, check again. check again, and check master code radiograph multiple. So this is a basic outflow of what you should do. You can change it. There's no harm in taking twice apex locator, 2 X-rays, do before and after cleaning and shaping, but do orifice widening, have a basic idea of the working length, orifice widening, use an apex locator, cleaning and shaping, and then take a master film radiograph or use the apex locator again. So basically what I'm telling is you have to do a crown down or step down approach. The step back approach is not valid nowadays. It was done before the advent of tapered instruments. So you have to do crown down or step down. There should be no contact with metal, ceramic, or any restoration. Remove all that. If you have a restoration, you can't remove it. Crown, use a Teflon tape over the root canal instrument, the middle third. Make sure your apex locator is touching the metal and the apex is also free. Teflon tape just around the area where you are inserting the file. Wait for 3 to 5 seconds for a stable reading. It will fluctuate, and don't take it as final till you get a stable reading. And one of the things which I found out is when I was researching for this article is that a reading of 0.5 millimeter or less is not relevant clinically in endodontics, at least, because it is not possible for us to assess less than 0.5. It is because of our limitations of our manual ability. Working length can't be 17.2 because that's it's very difficult to assess between 0.2 and 0.5. So that's why we take 0.5 is the reading. Working width is a totally different dimension. It's a horizontal dimension of the apex. It was first advocated by Joe et al. In DCNA. You have to do something known as apical gauging. You can use a master file or something to gauge the apex. The working width comes into play when there is cleaning and shaping with irrigants. So this is basically working width. It is shown multiple portals of exit with, it's not oval all the time, it's elliptical, and all canals are curved, only the degree of curvature varies, except for maybe your anteriors, maxillary, central, and lower central. All canals are curved, only the degree varies. And this is what a famous study which was done as far as 2001, micro CT study, which shows that 35% of your canal is untouched by your instruments. 35%. The green shows the untouched amount, the space. So your cleaning is not complete without what is known as the irrigants and the shaping. Another controversial portion is size of the apical preparation. The main use of the shaping was to get a good, clean, shielded objectives to the apex so that you have a good obturation. But nowadays, your shaping should be more to get access to the middle third for cleaning and shaping. You have to widen the orifice, get a good shape so that your irrigant needle goes to the apex, not to the apex point short of the apex. Your medicament can be placed in the apex. So that is also an important point of shaping. So what is the final apical size, to how large to enlarge? Again, initial apical size, file size will determine your master apical file size. You're starting with your canal is just 10 millimeter, no need to enlarge to 40, 15, 20, 25 max will do. Don't go beyond that. If your canal is 60, like in a young tooth or in a palatal tooth of a palatal canal of a molar, don't do till 120. Just do till 70, 80 and do proper irrigation. So you have to use your judgment here. Just because your canal is a palatal root of a maxillary molar is 60 size or a 50 size, don't increase till 80, 90 and all. You're going to rip apart the apical foramen. Use proper shape at least till 60, 70 and do good amount of irrigation. Vital and non-vital, again, vital tooth, the pulp will be vital, not infected. No need to increase so much. Can stop at around 25, 30 for molars. And non-vital tooth, you can increase more because of the presence of microorganisms. And be sure that one size does not fit all tooth. You cannot have a hard and fast rule that I'm going to do for this tooth this much, this tooth this much. It varies according to each tooth. So this is what I follow now is basically for vital tooth, 25.4% is more than enough. Distal or palatal, maybe 25.6 or 34%. 4% taper is the norm nowadays according to literature. You don't need to widen the orifice too much. You're going to remove the dentin all around, leading to a lot of other complications like fracture. So it need not look good. Okay, so somebody is drawing on my slide. Please stop. So cleaning and irrigation again. So cleaning and irrigation is the second most important thing. You can use hypochlorite 2 to 5%, chlorhexidine and non-vital, saline, irrigation needles. I need not tell you a lot of types, max size, safe and dead. What is important for you if you are starting off with endo or not doing complicated endo, you can use ultrasonics. I'll tell you just briefly. You can use ultrasonics for passive ultrasonic irrigation. You can use endo activator, or you can use a water pip, which is available in Amazon. This is basically used for flossing. It's not possible in where you don't have access, but it's known as a water pip. It looks like endo activator, but it's not. Doesn't have the contra angle. It works pretty well in anterior tooth. You can buy it and use it. And Mani ultrasonic files. And most important thing, if you are doing just normal endo, is something known as manual dynamic agitation. Your file or your irrigation needle is not going to go to the apex. So if you're done root canal cleaning and shaping to 25.4%, what is going to go to the apex? 25.4% GP. You can very well use that for dynamic agitation. Put it 1 millimeter short, use hypochlorite and do up and down motion of the GP. Or you can use a paper point, but GP is much better. I'm telling you, it's wonderful technique and use it for 4 to 5 seconds per canal. You can see the debris coming out while you are doing the irrigation. So if you are starting off doing endo, don't have all of these instruments, you can do something known as manual dynamic agitation using a GP 1 millimeter short of the apex and up and down motion. I use these for irrigation. It's very simple, nothing complicated. You can attach it to your scaler unit. You need something known as attach a tip, which looks something like this. Make sure this tip attaches to your ultrasonic unit. I have a Mectron, so this is I think E3 or something tip. You can get it on Amazon. You can get it Dencart, Pink Blue, anywhere you can get it. This is what it looks like. You can attach this portion to the ultrasonic scaler and your ultrasonic Mani U files to this portion. This is also this plate, which is not doesn't contain files or flutes. This is as a spreader. You can attach it with the help of this. Attach it to the ultrasonic scaler and agitate in each canal for I think around 10 seconds with the help of place the irrigant and use 0.5 to 1 millimeter, 2 millimeter short of the apex, agitate in each canal. It's an excellent irrigant. Hardly you cost 500 rupees, 300 rupees for the adapter and another 300 for the files. So very good. You can buy it in a lot of online stores. It's much value added thing to your sealer. Again, a lot of sealers, seal apex, bioceramics, again depends on your choice. If you are starting off and doing ultrasonic irrigation or ultrasonic obturation, go with seal apex because it's calcium hydroxide based. You can also do syngoxyreginol. Bioceramic sealers are there. Still a lot of studies going on. We have mainly used for single cone obturation. Now, once you have cleaned and shaped the apex, okay, you have to obturate using a three-dimensional technique. A lot of techniques, cold and warm. Cold is your cold lateral condensation, and warm you can use continuous wave. It's a lot of expensive equipment. around 1 lakh. Woodpecker comes around 60, 70. If you can afford it, well and good. Practice on extracted tooth. And it gives this is, if you ask me, the best method for obturation. But if you can't afford it, you can go in for something known as, again, obturation techniques. Again, you can use a ultrasonic sealer. This again takes a lot of time to explain the technique, so I won't go into detail. Again, you can get the ultrasonic. This is endostar spreaders, which I use, different sizes. You can attach it to the tip, place the master cone, do the initial lateral compaction, place it inside the canal, short of the working length, 3 to 4 millimeters short, and activate it without the irrigant for 10 seconds, and then remove it and keep on adding. So this is again, take some sort of learning curve. So you do an extracted tooth, you can get some amount of three-dimensional fill. What has gone beyond the apex is a sealer and not the GP. Sealer going beyond the apex is not a problem. Even GP is not a problem, but you have to be careful. Now, what about the future? Now, CBCT is the future, at least the present foreseeable future is CBCT. If you can afford the CBCT for the patient, go well ahead and going for it. Not in all cases. I'll give you a brief outline on when to do it. The real future will lie in when you get a workable endoscope or a oroscope where you can actually see the apex. A lot of ophthalmic scopes are available, but none of it has been developed practical purposes for your endodontic purpose. This is where going to be a game changer. Okay. So what is the CBCT, American Endodontic Association, and American Oral Medicine Radiology Association position paper? There should be no routine use for all endodontic purposes. You cannot take CBCT for all endo cases. It should not be used. Recommend the smallest FOV, smallest voxel size, and smallest MA setting in exposure time for your CBCT. You can take a small field of vision that is in the area of where you want to do, and just a small, if you check the amount of exposure, is just as much as taking 2 to 5 digital IOP. So it's not much if you check the output you're getting from it. So recommend an CBCT if you have any doubt. And if you have a problem diagnosing it, refer it to a oral medicine and radiologist who runs the center, or somebody who's got experience in dealing with CBCT, so that you get a proper idea of what it is. So it's not easy to read it initially. Even it's a learning experience for me. So you can just go through it, or if you have a doubt, consult a oral medicine radiologist or an endodontist who has sufficient experience with this. Okay. So one of my favorite quotes, which I got from my research for this article, is that the medical people, they will never touch you without having a CT scan or a MRI done on you. Okay, just imagine a doctor, surgeon does the surgery on you and opens up and then tells you, oh, there's something wrong, let's go for a CT. That never works. Okay, that's a medical view. So I think in a few years from now, 10 years from now, we are going to have something where we are going to have a limited scan or endoscopy of each tooth. We are going to find out what is inside each tooth and then doing an access cavity, or maybe an extraction, or maybe a perio treatment, or whatever. So we are one of the very few specialties when we don't have the provision of checking what is there before doing the treatment. We do something, we end up find some wrong resorption, then do a CBCT. Okay, so that's not how it works in the medical field, because you will not have a surgeon operate on you without first having a CT scan. So this is the most important question which I found interesting among the articles which was asked by Antonio in the Endo Journal in 2013. So this is what I would like to tell. This is a basic LRA principle for radiation exposure. LRA stands for as low as a radiation possible. Now it's changed to basically as low as a radiation diagnosable radiation. Okay, so if you want to take, if you don't minimize it so that you get minimum radiation, you have to have a diagnosis. So as low as a minimum diagnosable radiation. So that is a present concept. So knowing what to do and doing it properly basically depends on knowing the morphology, anatomy, and loads of experience. So that is makes the difference between a good academician, clinician, and a good experienced clinician or an endodontist. Hope you are all doing well in these Corona times. This 2020 has been a crazy year. I hope it ends in a wonderful way by getting the vaccine next year. And hope we all have a much better 2021. Thank you and a Merry Christmas in advance to you. I'm not wishing you a Happy New Year because looking at what happened in 2020, I don't want to be the first person to wishing you Happy New Year, so I'll wait for that. So that's all for today. Dr. Adina, I think.
Thank you, sir. Is there any questions? If anybody have any doubts or something, please put in the chat box. So one question is irrigation. Why do we use sodium hypochlorite in vital and chlorhexidine in non-vital teeth?
Yeah, irrigation. Why do we use sodium in vital? See, sodium hypochlorite is the best irrigant as we know as of now because it is the only thing we know which can dissolve organic tissue, pulp, which can dissolve the organic tissue. If you take 5% hypochlorite, I think if you have seen a lot of slides in with a lot of studies in I think 10 minutes, it can dissolve the tissue. And chlorhexidine is a antimicrobial. The antimicrobial action of chlorhexidine is much more than that of hypochlorite. Hypochlorite has antimicrobial, chlorhexidine has much more. It's a bisbionite. It has got antimicrobial action, and more importantly, it has got something known as substantivity. The action of chlorhexidine remains for a much longer time even after you flush it out. So that is the reason we use it in a non-vital case. And hypo, we can use both interchangeably, but in vital, I would advocate sodium hypochlorite, and in a non-vital, both sodium hypochlorite and chlorhexidine, because non-vital doesn't mean there's no pulp, there is necrotic pulp. You have to remove that. So use sodium hypochlorite and use chlorhexidine as a final irrigant between your treatment and give an intracanal medicament. Okay. Next question is there any medical condition which is a contraindication for electronic apex locators? There is no medical condition which is a contraindication for apex locators except maybe the pacemakers. Okay, the pacemakers are the present generation of pacemakers do not affect the working of, present generation of apex locators do not affect the working of present generation of the pacemakers. Sorry, so they do not affect each other as of now. That's what I know from the literature. But don't take a chance because the root length is not as important as a working heart. So I won't take a chance with the root apex locator and the pacemaker. Okay. And second is pregnancy. It's not a medical condition. It is it's a physiological condition. It is not contraindicated. You can take necessary precautions like a thyroid collar or a lead apron and take the X-ray. The apex locator, whatever, you can use it. There is no absolute contraindication for any condition except for patients with pacemaker. Is there any other question? First, yeah, I'll show you the first slide. 1 minute. Does the zero reading on the apex locator correspond to minor diameter of the major diameter? Depends on the apex locator you're using. I'm assuming that you're using the root ZX. If you read the literature instructions for root ZX, they don't have a clear answer. I read it multiple times. The zero reading on the root ZX shows you the minor diameter or the periapical tissue. You have reached the periapex. So if you want, you can take that as a root length. If you want, you can reduce 0.5, 0.1, I mean 1, whatever. So what I do is I usually maintain it as such or reduce 0.5. So zero reading is what you should try for in a apex locator. Don't take it to 1 or 2 and think that it is 1 millimeter short. It is not 1 millimeter short. It is just a guide to show you have reached somewhere near the apex, you are going correctly or you are going in the right direction. It is not, does not show you the millimeter. You have to go zero. Even somebody told me can go beyond and then come back to zero. Okay, even that is not a problem. You can just go beyond apex and come back to zero and take that as the apical constriction, and then if you want to reduce or maintain that as the apex. How often do you change metapex? If you are talking about the case which I showed you, which took 6 months, every 1 month. Don't keep on changing it every 1 week. And if you have a large lesion, you better to have 6 months treatment. Change it every 6 months, every month. Don't change it every week. Keep it 6 months, at least 3-4 weeks. Don't change it every week or every 4-5 days. Keep it for 1 month and change it every month. If you are dealing with a large periapical lesion, it's just a apical periodontitis. You just want to sort of paint the apex. Just 1 week will do. Okay. Limit of your extent of obturation of vital and non-vital case. Vital, I think I told you I take 0 as my apex locator and sometimes reduce 0.5 or sometimes take that. Non-vital, it is always, I think, at the apex because apical constriction, what I get 0 in my apex locator. So one more question I forgot to mention is, if you have a problem between your apex locator and radiograph, which one will you trust? It's again a dicey question. Given to me, I'll trust my apex locator. Okay, but if there is a large discrepancy and you need to show the patient that this is something wrong, it is still not 100%. I'm not 100% sure. But if the apex locator is showing me something wrong, I will go with the apex locator. If it is showing too much of short or too much of beyond, then I will check up with the X-ray. What is the name of low-cost mean for it? Low-cost equipment is nothing but Mani U files. You can get it from the online site. You can attach it to the EMS or Woodpecker. I use a Mectron. Only thing you have to check is you have to get an adapter, which you can fix to your scaler unit, and you can attach these files. So if you want, you can just contact me over the email or phone number. I will give it to you. By 1 minute. By theory PDF stuff near scissor. It is again minor diameter because as theoretically as we know, the periapical tissue starts from the minor diameter upwards or downwards, whichever two theoretically. The distance between the major and minor diameter belongs to the periapical tissue because there is cementum there. Its cementum is found there. It is not dentin there. So theoretically, it should belong to the periapical. So the apex locator shows you the minor diameter. So to answer your question, the apex locator reading, this is apex, shows you the minor diameter. If you are using root ZX, I'm not sure about the other one because I haven't used any other apex locator. Rudy asked me questions. I was there yesterday. He didn't have any questions. If a good apical seal is achieved, then and the middle and coronal is not good. See, it depends on the outcome. we have to wait for a few months to see if the patient has any symptoms. Second is if there is any periapical changes. Okay, there are two concepts. It's a good apical seal and see between a coronal seal and apical seal. People prefer a good coronal seal and a bad apical seal to a bad coronal seal and a good apical seal, because if you don't have a good coronal seal, your filling is going to leak. You just give a temporary or a glass enamel or a composite and send the patient. 5-6 months, 1 year, just composite will start leaking probably. The temporary will start leaking, and the saliva, the fluids, the microorganisms is going to end up from the coronal, and so just a matter of time, your root canal filling is going to start failing. So you need a good coronal filling. If you have a good apical filling and your coronal filling is not good, but if your coronal seal is good, should do. Okay, I am sure I made confused you. I'll explain better when I come there next time. Is there any other question, Dr. Adina?
Any other questions?
We have on technical clinical for metallic crown, Dr. Deepti. Metallic crown, I usually, after doing the access, you use a Teflon or a plumber's tape. It's available for 30 rupees in all these hardware shops. You know what a plumber's tape is, Deepti. You just use a plumber's tape, and just below where your file attachment, your apex locator is, put the plumber's tape just for a small portion where you think that the file will touch the crown, and then use it. You will get a much better result. Otherwise, the best method is to remove the crown. Okay, you can use a plumber's tape or a Teflon tape to overcome that problem. Okay, is that all? One new message.
Yes.
Somebody wanted the first 5 slides. Is there any other question, Adina?
No, sir. No, sir.
Okay, thank you all. Thank you, Dr. Adina, for the wonderful managing of the session. Went on flawless.
Yeah, I call our chartered secretary, chartered treasurer, Dr. Bijay Nair, for a few words. Doctor?
Hello.
Yes, sir.
Can you hear?
Yes, yes. Please, sir.
Okay. Hope everybody had a very nice and a very informative session from my friend and our branch member, Professor Dr. Ganesh. Actually, when I approached for a webinar, he had no reluctance, even though it was he immediately accepted, and it came a reality today. And I hope everybody had a very informative session, and thank Dr. Ganesh for the same, and Dr. Adina, the CD convener, for the arrangements. Thank you.
Yeah, Adina.
Adina, I need to say a word. Adina, hello.
Rudy, doctor, please.
Yes, okay, thank you. Dr. Ganesh, actually, this lockdown period, we had the opportunity to hear a lot of RC webinars from various faculty, I would say from a lot of, we had a lot of, would you consider that, let's say, coronal, middle, or whatever part of the RC treatment, but the apical third, what you have said is, I would consider it is the most important part of the root canal treatment. And thank you for giving that wonderful lecture. And I hope we can, focus more on the apical part for our treatment. And thank you. It was a really informative session.
Thank you, Dr. Rudy, for your kind words. 2 more doubts. Should I clear that, or can we?
Yes, sir. Please, sir.
I think somebody was asking about weeping canals. Treatment for weeping canals again is you have to undergo multiple visits with calcium hydroxide. You can try triple antibiotic base. It's not used much, but I think it's very useful for dealing with weeping canal and long-term periapical lesions. And the most important thing with dealing with all this is, again, I need to emphasize is having patience. Okay, you can't just treat each case, just give a 1 week dressing and wait for it to cure. Some will take more time and wait, give a dressing, keep the patient informed, make sure the patient has your number or is willing for emergency appointments in between your intracanal medicament appointment, and just wait. It will heal. Okay, all tooth, in my opinion, just wait for some time, give a dressing. Metapex is a wonderful thing for bony healing. Calcium hydroxide, plain calcium hydroxide is good, but if there is a large lesion, iodoform is essential for bony healing. So you can give it for bony healing, and weeping canals, nothing else but calcium hydroxide and multiple appointments. Okay. Next is the irrigant that we could use extrude while doing manual. It's very rare, but it's a possibility. But so you have to be careful. If you're using a masticone X-ray, 1 millimeter shot, the patient, from my experience, sometimes the patient will just get up like this. That means some amount has gone beyond. And don't use very, what do you call it, Tivamaya manual agitation. Just up and down motion slowly. That should do the trick. In my experience, it doesn't go beyond unless it's a blunderbuss canal, and in which case don't do manual agitation, or a very wide open. Such cases don't do. A normal case, premolar, lower anteriors, upper anteriors, do it carefully. 1 millimeter short motions up and down, 5 to 10 seconds, shouldn't be a problem. Okay, and even if a small amount, no, you need not use high strength hypochlorite. Use 1%, 2% is enough. Okay, that's all I think. Thank you all once again, Dr. Biju, for giving me the opportunity, ID Athingal, Sharon, Dr. Deepak, and Dr. Adina especially for the wonderful session. And all of those who listened.
Secretary, Dr. Deepak Estas, for vote of thanks. Is there?
Secretary, hello. Our secretary is busy with the patient at our pre-active dental clinic. We have, as you only know, we have started a free clinic for the differently able and poor people. And actually, he's on duty today in the clinic, and right now he's attending a patient. So, Dr. Adina, please deliver the vote of thanks.
Okay, so it was a very informative session today. Hope it will be very useful for everyone's clinical practice from today. We are very fortunate to have such an eminent faculty and around member as a faculty today. Thank you, Dr. Ganesh, for spending your time with us. Thank you, sir. Thank you so much. I would like to thank our president, Dr. Sharni Kalam, and our secretary, Dr. Deepak Esdas, for all the support. I also thank our treasurer, Biju Nair, former president, Dr. Arunas, for all the support given. At last but not the least, I would like to thank all the participants here for coming and making this webinar a big success. Thank you all. We expect the same participation for the coming webinars too. Thank you all. If you have any doubts, you can put your queries in the webinar group. It will be active for 2 more days so that we can clear it all. So thank you, everyone. Shall we end? Okay, thank you.